Welcome. Welcome to today's episode of Carren's Couch. Now, we're actually really excited to bring you today's episode because we've been working on this for a while. And today's episode is a compilation of all of our best shows and all of our best snippets. Now, we've decided that today we're going to concentrate on depression and mental health because on the 11th of September, we've got Are You OK Day coming up. And we were really fortunate to have the founder of Are You OK Day joining us here on the show, Carren, where his whole concept is a conversation can change a life. So he's coming up in this compilation, but the first person that we want to explore with you is Professor Gordon Parker, where we sat down and had an in-depth conversation about what depression is, how do we identify it, and how do we deal with it. Like, what really is depression? Can you define that for us in any way?
Yes, and I think as part of that, I'll try to distinguish between what you could describe as normal depression and clinical depression.
Great.
So, to my mind, to feel depressed is to have a depressed mood and to have a drop in your self-esteem and self-worth and to be quite self-critical. And that's a depressed mood. And in the past, we went around Sydney and tapped people on the shoulder and said, have you at any stage experienced a depressed mood, been self-critical, tough on yourself, had lowered self-esteem, felt worthless, hopeless and helpless, and felt like giving up? And the percentage who affirmed that question was pretty close to 100%.
Yeah, right.
And when we asked them how many times a year they felt like that, the average was 6 times. And when we asked how long it lasted, most people said minutes, hours, or a couple of days. So the first point I'd make is a depressed mood is a universal experience. We all get depressed. And then either we have a spontaneous improvement or something nice happens, the Wallabies win or whatever, and we become happy again. Now, what we've seen since the 80s, the official classificatory systems have blurred the boundary between clinical depression and normal depression. So just going ahead to what is clinical depression? Clinical depression should have much greater severity, obviously, than a depressed mood. It should have a tendency to last for extended periods of time. It should be disabling so that the person either can't get to work, or if they get to work, they can't actually fire up. So there's either absenteeism or presenteeism. And some of the features should be far more gravid, so that the individual, if you look at them, you'll often find there's a loss of light in the eyes, they can't get any pleasure in life, they can't be cheered up, they may find it very hard to get out of bed and to move, their appetite and their sleep may be disturbed. So clinical depression is probably close to the statistic that we've heard in Australia for the last decade or so, probably affects about 1 in 4 women and 1 in 6 men over their lifetime. Right. But it is not the same as normal depression. And DSM has progressively lowered the cutoff for the features required for clinical depression, that it has blurred it in with normal depression, and it has also brought in grief into the equation, creating tremendous confusion.
Yeah.
There were this long-standing distinction that there were some depressive conditions that were essentially biological. They ran through families, very physical, and we've known since the antidepressants were introduced that people respond very well to antidepressant medication. But there's a second broad heterogeneous group of conditions that are more reactions to life event stresses, possibly contributed to by personality style, seeing the world in maybe in a pessimistic way, being hard on oneself, maybe being too perfectionistic. And this second broad group of depressive disorders doesn't respond as well to medication because there's no underlying primary biological process.
Right.
If it's come from your personality style that you think you're hopeless and useless, then it would be far more appropriate to consider a psychotherapy that tried to build up your self-esteem. If it came from a huge life event trigger, it would be more important to have a counsellor who helped you to either neutralise the stressor or come to terms with it. So what I'm arguing for and have argued for a long time is that we need to subtype the depressive disorders as occurs in the rest of medicine. The big problem in Australia, as in the rest of the Western world, is that most practitioners apply the same treatment to whatever type of depression that turns up. So if you've got depression type X, be it melancholy or reactive depression, and you go to a GP, you're highly likely to get an antidepressant drug.
Yeah.
Same depression to a psychologist, you're highly likely to give cognitive behavior therapy. Go to a counsellor, you're highly likely to get counselling. Go to a lady wearing a caftan and you're likely to get crystal therapy.
True.
I know of no other Procrustean type model in the rest of medicine that operates that dumb principle, where the background discipline or training of the practitioner shapes the treatment. And as one of my colleagues said,
Absolutely.
it's rather akin to the old statement that if all you have is a hammer, then everything looks like a nail. And the consequence of that model is that some people with rip-roaring biological conditions that would respond rapidly to medication get months or years of psychotherapy that does nothing. But conversely, we see many people who would really benefit from a psychotherapy being essentially giving medication after medication after medication to no benefit. And that doesn't happen in the rest of medicine. So we need to have sophisticated assessments. So for instance, on the Black Dog Institute, there's a screening measure for bipolar disorder. That is completed by more than 30,000 people per month and has an overall level of accuracy of about 80%.
30,000 people per month?
30,000 per month, and it has an accuracy of about 80%. So I think that what we've seen in the last decade is a number of other options apart from just simply seeing your general practitioner.
Yeah.
So what I'm arguing for, obviously, is we need sophisticated assessment.
So if somebody out there who's either listening to the podcast or watching the show, if they suspect that they have had that sensation of that's ongoing, that's sustaining itself, what would you recommend would be their best first step?
Well, I think there are a couple of first steps. I mean, if you've got a really good general practitioner who is interested, keen and committed to helping people with mood disorders, that probably is a good step.
Sure.
But see the GP more as a gatekeeper to referring on for a sophisticated assessment. The second thing, again, is I've mentioned the Black Dog Institute. There's a lot of information on the website talking about the different types of depression and the preferential treatments that we would recommend. So getting that information can be pretty important in allowing people to decide where they go next. The third thing I would suggest is if there's somebody that you know who's experienced depression and they've been well managed, find out how they got that trajectory, because often they'll be able to say, well, Dr. X or psychologist Y is particularly good, and so on. So that's one of the great advantages that we're talking more about depression. People are sharing their stories of who's good. A patient should expect when they see a professional and get a sophisticated assessment, they should, within the first couple of sessions, get a precise diagnosis that they are depressed, what type of depression they've got, what are the likely contributing factors, what the management plan that is being recommended, and how long it will take to put in effect and be expected to produce results. That is, we need to stop a lot of meandering that goes on and have much more incisive practice by the people who are working in the area, and that should be expected by the public. And that's certainly, I think, the model that we are seeing increasingly, but we've got a way to go before we catch up on it.
Now, coming up next, we had a conversation with Jane Newman. Now, she came to us all the way from Switzerland, and she has a book that she's written called Thank God for Antidepressants. It's such an interesting conversation as she shares her personal journey and her personal story about how she's oscillated between taking antidepressants and also going drug-free. So what did you do when you started to feel that you were losing it? what was the first thing that you did?
Well, I cried.
I bet you did. I bet you did.
And my husband took me to the doctor, our family doctor, in Abidjan, where we were living in Ivory Coast, who was a wonderful man, such a wonderful man.
Yeah.
And he put me on antidepressants, after talking with me. And I didn't really care what he put me on, quite honestly. I didn't even think about antidepressants, not antidepressants. I just said, give it to me. I'll take it, anything.
You were just looking for some relief, really.
I was really, I use in my book the picture of a drowning person. When you're drowning, you stick your hand up for help, when your head's already under the water. If someone takes your hand and pulls you out, you don't care whether it's a pirate.
You're taking it.
You're taking it.
Yeah.
And you take the other things later down the line.
Yeah. Oh, I can so resonate with you in that sensation and that feeling of just pure desperation and just somebody give me something.
Especially since 2010, which was a fairly cataclysmic year. I call it the worst and the best year of my life.
Oh, wow.
Where I realized I needed to change antidepressants because at one stage I did manage to stop the antidepressants, and I lived about 10 years without them.
Oh, that's huge.
But then I crashed again,
right? Even
though I vowed to myself I never would. But there was more stuff, that needed to be dealt with, and it was also a very challenging situation.
Can you elaborate on that at all for us, just so that our listeners and our viewers have a perspective?
Yes, it's something everybody can relate to. Yeah. But basically really heavy personal life with 4 children, having come back from Africa and trying to settle into a Europe that had moved on, and which we had to try and understand, including the church scene. We didn't feel at all at one with the church scene. They'd moved on, hugely. Our children were struggling in school. So there was all that personal side. There was heavy work. And then we moved house. And this was literally one day to the next. One day, my husband and I were cleaning the place we'd moved out of. And we were having a great time. It was such a wonderful time for the two of us working together on cleaning the house. And we were laughing. And the next day, I was a basket case. It was shattering, totally shattering. And then I just couldn't. Again, I was back in that prison of anxiety, that just keeps you there, and you just can't face breakfast again. See, I condemned myself. I said, you obviously haven't learned a thing. You should be able to do without antidepressants now.
Wow.
And she said no. And then she explained to me about what it is. And she said, if you lack serotonin and also noradrenaline, which is a hormone, she said it's a chemical imbalance in your brain, and we can observe it. She says, I don't feel I need to in your case, but she says, I have patients in clinics, and we can observe before treatment, during and after, and we can see changes. And suddenly I thought, it's something real. It's not just, well, I'm pointing at my head because it is in my brain, but it's not just in my thinking.
Yeah, you didn't make it up.
I didn't make it up.
You're not pretending.
I don't need just a kick in the behind,
Do you know
that's what you say in Australia?
That's exactly what we say, only we're not quite so polite. Yeah. You may know people who have suffered with depression and who are not saying anything. They're not doing anything about it. They're living underneath the cloak of silence when it comes to the way that they're feeling. And, there is so much help out there nowadays, and there's such... The lid has been lifted on depression, where we're no longer suffering with the stigma that depression used to have, because now we're starting to understand it more, we're starting to relate to it more, and we also have solutions, which I think is just beautiful and amazing that you, Jane, have found a long-term solution that has really worked for you. Granted, it's been one hell of a journey, but what you've gotten out of it along the way, it's been worth it.
Yeah.
And I always say, nothing is for nothing. Everything happens for a reason. It doesn't matter what it is. There is purpose and perfection in every experience, provided we go looking for it. The only time something's a mistake is when we make it a mistake. And I think that's a real message that you, Jane, are the epitome of. So thank you. Thank you so much for sharing your story with us.
You're welcome, Carren.
So cast your mind back to episode 9, where we introduced you to Graham Cohen, author of a book called Back from the Brink, where he interviewed over 4,000 people who were suffering from depression.
Looking back, I really know that a lot of my depression was triggered by, stressors, whether it was for work or things like that. And I obviously have a predisposition. I've had 5 major episodes in my life, and I know that I'm vulnerable, and that's why, I'm now just so rigorous about doing things to prevent it. But ultimately, I guess it was a stress, when the business collapsed that really triggered it. And I think then it was a loss of meaning and being lost in the treatment pathways that was so difficult and so despairing. Yeah, you probably see in the back there's what I call a poster of a moodometer. And basically it goes from, 0, where life sucks, you really don't want to go on, to 10, where you're sensational, you can cope with anything. And when people are really low, and I'm talking in the 0 to 3 range, you have to do stuff, and there are very practical things that you can do. And I really, in researching the 4,000 people, I asked them 60 options to say what they found to be most effective in their recovery. And I wasn't looking for one single answer, because I know that everyone's situation is unique. But I was looking for themes. And so I asked 60 options. They include all the common medications, all the common psychological approaches, but also all the lifestyle strategies. And what came out was an acronym of CARE. And so the C stands for compassion, and emotional support, whether it be from loved ones or support groups, and even from medical professionals, was judged as being the most important thing by people that have come back from depression. Much more important than the actual treatment. I differentiated by saying, consider the reassurance versus the actual treatment, and they said that the reassurance and the emotional support was most important. So, and what that means is that not just from a personal point of view, but it also has massive implications in the workplace, because 34% of lost productivity is through depression and stress disorders, being lost through absenteeism and presenteeism. So there's huge, massive financial costs and social costs. I really, in terms of things that people need to do to become more resilient, it is about making sure that we do make time for regular activity. But the final thing that took them through transformation was getting greater meaning. And that often came in the form of mental health advocacy, really fighting for the rights of the mental health. Like Patrick Kennedy has devoted his life now to reform in the American healthcare system for the American thing. Alistair Campbell, who rode the pinnacle of success as a chief advisor to Tony Blair, says his most rewarding work now, even reflecting back to when he worked with the Prime Minister, is advocating and promoting change and sharing their stories of hope. That really, I think, is the ultimate recovery, and sustainable recovery. Sure, you have to do the exercise, you have to have contact with family and friends, and if necessary, you need, good mental health professionals. But sustainable recovery comes through, I believe, in finding meaning, and I talk about how to go about doing that in the book.
In the book, Back from the Brink. So finally, we brought you Dr. Yapko. Now there's a controversial guy in and of himself, where he talks all about teenage depression. And he's not concerned about whether we're labeling it as depression or whether we're labeling it as a certain melancholy or a sadness. He's actually just concerned about how our kids are feeling and making sure that we've got the tools to support our kids, right the way from a peer support group into the home with our parents.
So there are a lot of different levels of analysis that we can talk about during our time together. But certainly the thing that's most compelling that I think is of concern for all of us is seeing that the rate of depression is increasing in every age group around the world, according to the World Health Organization. And when we look at the demographics, the largest group of depression sufferers are the 25 to 44-year-olds. And of course, they share many common characteristics, but one of the characteristics that they share is that they're in their prime childbearing years.
Yes.
And so it's very interesting that you have the largest group of depression sufferers raising what are now the fastest growing group of depression sufferers, namely their children.
So it's contagious.
Depression is contagious, and funny you should mention that. That's the title of my last book on depression.
Oh, look at that.
Depression is contagious in a social sense, that we learn the coping skills or not from other people. We learn the problem-solving skills or not from other people. We learn social skills or not from other people. And so the kinds of factors that set people up of any age, teens included, to be depressed are socially acquired or not. And so from my perspective, what I'm always looking at is what are known as the risk factors, the vulnerabilities. What are the things that happen in a family? What are the things that happen in a culture that increase the likelihood of people suffering depression as a result of being a member of that group?
How does a parent identify what is actual depression and therefore requires serious attention versus perhaps this loneliness or general sadness that humanity tends to experience? And do you agree with that view?
Well, those differentiations matter to clinicians. They don't matter to people. To me, calling it melancholia or calling it Ralph doesn't really matter to the kid who's suffering with it. So, what I'm interested in is what is the quality of this person's experience? What are the things that they're facing that they don't know how to handle? And if it's loneliness, fine. What are the kinds of social skills this kid's going to need to develop if he or she's going to develop any meaningful friendships? If it's about being stressed out by school, then what are the skills this person's going to need to develop? What's interesting is that from a treatment perspective, when you identify what the skills are that people are missing and provide structured means for people developing those skills, they do better. It's no coincidence that the therapies that have the highest treatment success rates are all therapies that teach different kinds of skills. So one of those is the cognitive behavioral therapy, which teaches people how to think more clearly and how to use information more skillfully. The interpersonal model of treatment, which emphasizes the importance of relationships and social skills. So, there's no one pathway into depression, there's no one pathway out, but certainly what we do know is that the more active the treatment is, the more it requires skill building opportunities and provides means for building those skills, people do better. And that's particularly true, not just from a treatment perspective, but when I started studying depression 40 years ago, we couldn't say very much about treatment and we couldn't say anything about prevention. And now, all these years later, we have taken these treatment strategies of active skill building approaches and applied them preventively. We've integrated them into schools and been able to demonstrate that when kids learn these skills, they have much lower incidences of depression, and when they do suffer depression, the depressions are much less severe and of shorter duration. Prevention works, and you can't drug people preventively, and that's one of the limitations of the pill popping approach, is that's a mop-up approach. It's not a prevention approach.
I just want to tattoo that on my forehead. I think that is absolute gold, that you cannot drug people preventatively. That's absolute gold. And also too, your distinction of depression there, it's not just about what is depression and let's define it. It's about the experience for the person. And if the person is suffering, bottom line, what are we going to do about that? And,
exactly.
And is it a case of medicating or
the fact that you give this person a label, unfortunately, for a lot of people, then all they do is wear the label.
It's true. You live into the diagnosis.
Recovery is absolutely possible. See, the problem with any problem in the mental health field is that these are ambiguous. We don't have a gene for depression that we can point to and say, there's the depression gene. We don't have this hypothetical biochemical imbalance that has yet to be proved. No one has ever proved that there's a shortage of serotonin or a shortage of norepinephrine.
Well, why do the doctors tell people that? Why do the doctors tell people that you have a chemical imbalance, therefore here, take Zoloft?
That has been the pharmaceutical industry's tagline for years. That's how they sell drugs. And unfortunately, this is one of the things I described in the first chapter of Depression is Contagious. The most prestigious medical journal on the planet, in most physicians' estimation, is called the Journal of the American Medical Association, or JAMA. And about 4 years ago, JAMA wrote a blistering editorial that since the drug companies had been caught in lies, deceiving people about how effective the drugs are, inflating their claims, and the journals had been duped because the drug companies had paid highly recognizable physicians to put their name on drug company research, a practice called ghostwriting. And JAMA wrote an editorial that just blasted the drug companies, and they did a mea culpa saying, we've let ourselves be duped in publishing this research that is then disseminated to physicians. So physicians think they're reading current research, they think they're reading non-biased research, and as it turns out, they're reading contaminated research and unfortunately buying into it.
And so, therefore, the patient is the person who's paying the price.
Right. So that controversy is reaching its zenith at this very moment. This is what's going on in the world of the pharmaceuticals right now, and I think you'll be hearing over the next few years. It takes a while for information to disseminate, but I would predict that over the next few years you're going to be hearing physicians being less enthusiastic about prescribing these drugs and becoming more enthusiastic about encouraging people to get active, structured help that can really teach them the kinds of skills that all people need to have. Drugs cannot teach you coping skills. They cannot teach you social skills. They cannot build a support network for you. They cannot change your history. They cannot do the things that people need the most help with. And so that's why a good psychotherapist is worth their weight in platinum. The problem is that there aren't enough good psychotherapists to go around. And so people really need to be educated. It's why, I've written now more than a dozen books, and most of them are for the profession. But there are 2 books that I wrote for the general public. One is called Depression is Contagious, and the other one is called Breaking the Patterns of Depression. And I wrote those because there's so much great research that never reaches the people who most need to hear about it.
So the purpose of today's compilation show is to really encourage everybody to really get behind Are You OK Day. Having one conversation with somebody and asking them, are you okay? And genuinely being concerned for their welfare is really what Are You OK Day is actually all about. So we implore you to talk to your friends and talk to your family and just check in with each other, because you never know until you ask. So join us here next week on Carren's Couch. Go to our Facebook page and post all of your comments and your questions at allthews.facebook.com/Carren's Couch. You can also ask your questions and post your comments on our website at allthews.carrenscouch.com. And we're going to see you here, same time, same station, next week on Carren's Couch. Bye for now.